Ladies and gentlemen, I wish to thank the Arab Thyroid Association for inviting me to be part of this meeting. It's a great honor and a pleasure. I'm sorry I won't be able to take part in the discussion, but if there are any questions, I will be very happy to receive them by email, and I'll do my best to answer them as quickly as I can. So if there's just one single thing that I would be wishing that you remember from the next 20-minute talk is this 5mx, and it will become apparent of what this is shortly. But I'd like to share with you one of my favorite pictures. This is a painting by Luc Feldis, painted at the end of the 19th century. It is called The Doctor, and it depicts the story of a very sick child who probably is suffering from infectious diseases. And the doctor has spent all night with this child. The parents are in the dark corner, lost faith, but the doctor is still attending to the child. And it is a picture that was inspired from Luc Feldis' own experience, because sadly he had lost his son a few years earlier. But it's interesting that he painted this to put on record the status of the doctor in our time. And it is perhaps paradoxical, but I think very telling, that there was a terrible outcome, and yet the parent was very satisfied with the care that they received from the doctor. And if we reflect on what our contact with patients has evolved to, we find ourselves today barricaded behind screens, and a big part of the care that we deliver is in this format. And if I kind of reflect on my own experience going back several years when I first started in endocrinology, it was not unusual to walk into an endocrine clinic and be able to make a spot diagnosis. This is no longer usually the case, because patients with a disease label don't usually look any different from the normal background population anymore. And I'm also reminded of my first attendance to the British Thyroid Club meeting in 1989, where the president, Richard Bayliss, talked about subclinical thyroid diseases. And here we are, 35 years later, still being talking about the same subject. And his take on this was that subclinical thyroid disease is a myth invented by biochemists. So I'd like to develop that a little further. So what I would like to do is talk about subclinical hyperthyroidism, but I won't say anything about overtreatment of thyroid hormones or the very specific scenarios of pregnancy and childhood. The definition is purely biochemical. It's a low TSH with the normal free thyroid hormones. And some authors classified it into mild or more severe, depending on whether the TSH is detectable by modern assays or not. And the prevalence is said to be around 1%, but it does depend very much on the iodine status. So in countries with iodine deficiency, the prevalence is much higher, up to 16%, and increases as the population gets older. We do know quite a lot about the natural history, certainly what happens a year after the diagnosis, and in 0.5 to 7% of cases, they progress to overt hypothyroidism. But interestingly, the majority, if you repeat the thyroid biochemistry, revert to normality, and that's an important point to remember. The differential diagnosis is usually between non-thyroidal illness or drugs and subclinical hypothyroidism. And if there is a history of illness, obviously, it's much more likely for this to be sickly thyroid. And if the TSH is completely undetectable, it's more likely to be subclinical hypothyroidism. And the level of free T3 also helps, because it usually is low or low normal in non-thyroidal illness. The causes are pretty much the same as for overt hypothyroidism, shown here, and the treatments are also pretty much the same as for overt hypothyroidism. But I'd like to illustrate some of the intricacies of this diagnosis by sharing a case with you. So this was Mrs. A, an 82-year-old woman who, for reasons that weren't clear to me, had routine blood tests by her GP that included thyroid function tests. And she had undetectable TSH with a normal 3T4. The referral letter was extremely laconic. It just simply said, please see and advise. And she attended with her daughter, who actually did most of the talking, and she was very concerned about her mother. And her first sentence was, I've been reading about subclinical hyperthyroidism, and I'm so pleased that the cause of mummy's forgetfulness has been found, and you will put her right, doctor, won't you? And then she quickly added, by the way, I'm a lawyer specializing in medical negligence. So with that kind of introduction, of course, one does what we train to do to assess the patient. And in terms of history, the forgetfulness was relatively mild, but progressive. But she still had mental capacity, could decide for herself. And she had a history of hypertension, was taking some medications, shown here, and would have been simvastatin. And in terms of examination, there was very little to find. She was thyroid, she had a small nodular goiter, sinus rhythm, no curvature in the spine. And so the question that arises in a case like this is, what do you do next? Do you need some more information? You usually do. And here's the 6 options that I can think of. And I'll take these one at a time. 3T3, I really think is important, and it is definitely something that one must check, because remember, it's the active hormone, and if the 3T3 is elevated, even when the 3T4 is normal, then this becomes overt hyperthyroidism, and the patient needs treatment. No need to discuss this much further. In her case, the 3T3 actually was normal, though a little closer to the upper than the lower end of the range. What about the antibodies and an isotope scan? I would argue that you only need these if you've already decided to treat the patient and you're wondering which treatment to choose. A DEXA scan looking for osteoporosis, 24-hour ECG looking for paroxysmal atrial fibrillation, they may help if you're still uncertain about whether to treat or not. And 5-MX is an important part, and I will discuss this a little later. So in summary, here we have somebody who has cognitive impairment and subclinical hyperthyroidism, and a daughter with very high expectations, who is a litigation lawyer. And the question then that arises is the obvious one. Do you treat or do you not treat, and instead offer some monitoring? And in order to answer this, that we need to have a little information about what are the consequences of treating or not treating. And if we think about dementia, which is right at the top of the agenda as far as the daughter is concerned, then there are several studies looking at dementia and subclinical hyperthyroidism. This is a meta-analysis that puts them all together, and the authors of this meta-analysis concluded that subjects with subclinical hyperthyroidism may have a higher risk of dementia compared to those with euthyroidism. Here you can see the confidence intervals are really quite overlapping, but overall there is a positive association. Then what about overall mortality, cardiovascular mortality, and atrial fibrillation? Again, there are meta-analyses. This is one of them, which shows that there is an association with total mortality and cardiovascular mortality and atrial fibrillation. With regards to osteoporosis and fractures, this meta-analysis included more than 70,000 patients followed up for quite a long time. And this also shows an association with hip fractures and any fractures. But then we also need to ask ourselves, what are the gains if you treat such a patient in terms of these 4 outcomes? And the short answer to that is that we don't know, because we don't have evidence from prospective randomized control trials. And that's not because people haven't tried to find the answers. And I'm certainly aware of at least 4 randomized controlled trials that have started but never completed and have never reported. And the reason, I think, is that these are really quite difficult studies. They require a huge number of participants and long follow-up periods. So we are in a situation where we know that there are associations, and that is undisputable. I think that subclinical hyperthyroidism is associated with all these poor outcomes. Is there a causative relationship? It's, I think, possible, probable. But does treatment of subclinical hyperthyroidism prevent all these outcomes? We really don't know the answer to that one. What, in my opinion, is not controversial is if a patient with subclinical hyperthyroidism has atrial fibrillation, then I think it is worth treating to try and increase the chances of reverting to sinus rhythm and staying in sinus rhythm. And there's another scenario, not very common, where patients have progressive osteoporosis and fractures despite taking other measures. In that scenario, I think it is worthwhile treating the subclinical hyperthyroidism. What about guidelines? You can always go to guidelines and look for inspiration. And the European Thyroid Association produced guidelines in 2015. And in a nutshell, what they say is that if the TSH is completely suppressed in patients over the age of 65, they recommend that the balance is in favor of treating. And they suggest that in all of the cases, then you may find it helpful to know what the DEXA scan shows and what the 24-hour ECG shows. The same year, the US Preventive Services Task Force also produced a guideline which was much more conservative and in fact recommended against testing or treatment on subclinical hyperthyroidism. The American Thyroid Association the following year issued guidelines that were a little more aggressive than the European. So besides suggesting treatment for anyone over the age of 65 with suppressed TSH, they also recommended anyone, any age, who has risk factors should be considered for treatment. And interestingly, most recently, this is a publication just from last year, it's a systematic review of subclinical hyperthyroidism guidelines. And you may be surprised to know, I certainly was, that no fewer than 22 guidelines have been published between 2007 and 2021 on subclinical hyperthyroidism. And they vary really quite substantially in terms of diagnostic approaches, the thresholds at which treatment is recommended, and even the monitoring intervals. And this just reflects the lack of good quality long-term studies. So let us consider the situation where you have decided to treat. Which treatment do you choose? And here's the list. It's the same as for overt hyperthyroidism, although new technologies have also come in the therapeutic arena. And I'll just remind you that the benefits of treatment are theoretical, and the downsides, of course, are the side effects. And again, I'm telling you something that you already know. You use antithyroid drugs, you have a 15% chance of minor side effects, up to 1% chance of life-threatening side effects. And of course, patients need monitoring, and there's a significant risk of inducing iatrogenic hyperthyroidism. If you use radioactive iodine, even with relatively high doses, there's 1 in 10 chances of needing more than one dose. There is the hassle of complying with the radiation regulations. They need regular blood tests, hypothyroidism, very highly likelihood of that occurring. And in some cases, you can exacerbate the thyrotoxicosis and even induce thyroid eye disease. Surgery, for most cases, is just too drastic unless there is symptomatic goiter or suspicion of cancer. And the new technologies, I think, this is my personal opinion, that there isn't enough known about it yet, but they may certainly have a role. So how do you decide whether to treat or not when there is so much uncertainty? Of course, you need to be informed about whatever information is available, and we'll need to be aware of all the potential options, including not treatment. And you have to be guided by the principles of the Hippocratic Oath of doing no harm and respecting the patient's autonomy. And this is, ladies and gentlemen, where 5MX comes into, which I think is probably the most useful bit of information. And 5MX stands for 5 minutes of extra history, focusing on the patient as a person. And I'll show you what I mean by that. So if you apply for the 5MX in this particular case, it transpires that Mrs. A is incontinent 3 to 4 times a week and tries to conceal it. And you can imagine what a nightmare that might be if you choose to use radioactive iodine. She gets urine infections 3 to 4 times a year. And again, when this happens, if you use antithyroid drugs, patient has infections, you will need to act and get an urgent full blood count to ensure that she doesn't have agranulocytosis. It turns out that she hates going to the doctors and having blood tests, and it is a real struggle convincing her to take her medication. One of the most important parts of her life is seeing her grandchildren that visit her regularly, and gets very upset when the routine is disturbed. And so a discussion followed with Mrs. A and her daughter, where the diagnosis was explained, all the potential treatment options were discussed, potential side effects of treatment, the potential benefits, which I had to emphasize that, in my opinion, it was highly unlikely the treatment would cure the forgetfulness. And I think we as clinicians need to do a little more than that, and that is to come off the fence and give our personal opinion, because that's what patients are there for. And my assessment and conclusion was that in her case, I did not recommend treatment, but suggested that she should have annual thyroid function tests. And it was really quite revealing. At the end of the consultation, I asked her whether she had any questions, and she said, "Doctor, I've had a good life. I don't want any more tablets or blood tests." And the medical negligence daughter agreed, but expressed disappointment that I could not cure her mummy's dementia. So, in conclusion, ladies and gentlemen, there are associations between subclinical hyperthyroidism and poor outcomes, but these are rather weak. And I think, this is my interpretation, that any treatment effect is likely to be very small. And my understanding of the evidence is that the balance of benefits versus side effects tend to lean in favor of no treatment for the majority of patients with subclinical hyperthyroidism. And I would also suggest very strongly that when we find ourselves in a situation of uncertainty, which happens in clinical practice very often, there is an instinctive reaction to turn to the guidelines, which usually don't give us the answer. And instead, I would suggest that 5MX is much more likely to be informative. And so medicine is a two-faced entity. There is the science, which is, of course, very important, and it's based on the knowledge of the disease. But the other side is the art of medicine, which is based on knowing the individual patient. Thank you very much for your attention.